the current status of robotic surgery in prostate cancer. Since we are already running slow, I would request you to quicken the pace. Thank you.
Good morning, everyone. So without wasting time, I'll start with this presentation, robotic surgery in prostate cancer. And where do we stand? So for Varanasi, I can say we are standing waiting for a robot. So starting the presentation now. Yeah. So epidemiology of the prostate cancer needs no introduction for the audience today. And from a surgical point of view, open radical prostatectomy has been the mainstay for the last century. I would say for the beginning of this century. Recently, in the last 20 years, the minimally invasive approach, laparoscopy and radical robotic prostatectomy has taken over. And now in the United States, with data we have, around 90% of prostatectomies are being performed robotically. And it's not a small number. As Dr. Vipul Patel, who is one of the pioneers, performs around 600 robotic prostatectomy himself. So you can see the numbers in a country like United States. So we have epidemiology on our side. Now coming to the history, it said that to understand your today better, you should know your past. So I'll start where it started. It started in 1905 when Hugh Hampton Young, who is the father of modern urology, first described technique for prostatectomy. It was a perennial approach, and at that time, a brave effort for a surgical cure for a malignancy. However, it was a pre-antibiotic era, and this technique has its own disadvantage, or what you can say some problems for the patient. That time, the vision, the instruments was not so good. Perennial approach, the anastomotic bleeding, infections were very high. So with all these, in 1930 edition of Bailey and Love, it mentioned it was severe operative morbidity and 10% patient died after this surgery. So it was quite a morbid surgery and with associated mortality at that time. Till the time Dr. Millen in 1948 described the abdominal approach through the extraperitoneal route. This changed the scenario, and more patients were getting the surgery done. But still, the results were not very good. It was not encouraging. And when in 68, a line from Bailey and Love, radical cure by surgery was described as playing very little part in management of prostate cancer. So this was the scenario of surgery for prostate cancer as you can in 1970. So what changed in what I can say a landmark in the management of prostate cancer was by Mr. Walsh, and I think every urologist or surgeon knows his name. So he was the one who described the neuroanatomy of the prostate. And actually in 84 did the first nerve sparing prostatectomy. And after that, I think the role of surgery is where we see today as a major part of a multimodal treatment for prostate cancer begin. So as you can see in this graph, the bottom, you can see prostate, and this is the mortality percentage between 94 to 2003. I have taken this slide from Dr. Walsh's presentation on YouTube. And after his efforts in this decade, 90 to 2000, there was a decrease in the mortality associated with prostate cancer. Also with the discovery of PSA and better prostatic anatomy during the same period. So altogether, this led to better patient care in prostate cancer. And this picture is taken from 2008. The gentleman on your right side is Mr. Walsh. And the left side, can anybody guess? This picture is taken in 2008. This is his first prostatectomy in 84. This is his first patient in which he did his prostatectomy, and he's still hale and hearty and continent, and for a man, potent, sexually active in 2008. So that I think is a salute to his effort for what he did for prostatectomy. But still, as science evolves, we had evolution from 1905 to 2020. Neuroanatomy was described in 84. In 2000, we had laparoscopic prostatectomy, followed by the role of robotics in 2001. And from that point, there is no looking back, actually. There has been a lot of studies, a lot of modification in how we manage prostate cancer surgically. And I am going to talk about this in the coming slides. So laparoscopy was on it uphill in the 90s to 2000, and the urologists were not far behind. So first laparoscopic prostatectomy was described in 2000. Due to the narrow pelvis and the vision associated, it was a difficult surgery to master, and learning curve was great. So that led to surgeons looking for further innovations to improve their outcomes. This then came the role of robotics. So describing robotics for the non-surgical, our colleagues, everybody who is present in the audience, robotics were basically designed by US Army, but were looking for something they can treat their shoulders while in the battlefield after gunshots. They were looking from tele-robotics, and that led to innovations from 1983 to discovery of the robots in orthopedics. And finally, Da Vinci, the intuitive surgical, took over, and they made the first robot in 2000, which pictures here you can see the Da Vinci robots. The initial robot had only 3 arms, one for the camera and 2 for the surgeon. And this is the brief description of the main surgeon's console. You can see the operative field console with 4 arms, the vision cart, and the bedside assistant. So this is the overview of the robotic system what we are operating at this time. As the time goes by, we see modifications in the robotic system also. We have better vision, a more single arm to do better surgery. And now we have techniques like Firefly to assess the vascularity of our margins. A lot of things have improved from the model S, SI, and XI. Now, I have told you about the robotics, what we have done, but when we are talking, we have to talk about the outcomes of how it has contributed. So in the literature, it is always about the main outcomes, with 3 outcomes, I will say: the oncological outcomes and the functional outcomes. Oncological outcomes basically your positive surgical margins, your biochemical free survival, and the functional outcome will be related to potency and continence. Continence comes first. With the improved survival of the patient, now the recent literature is looking at pentafactor, in which they are counting the post-surgical complication and negative surgical margins also. But the issue with this is these are mostly single surgeon reports in the initial 2000s, and the definition used, because we are seeing continence and impotence over a period of 1 year, 2 years, 5 years, are questionnaire based, and these questionnaires were not validated or not standardized. So that's why there is heterogeneity in the data or results by various surgeons. So we were looking for some meta-analysis, randomized trial, and we had to wait till 2016 when a randomized trial or meta-analysis came from Australia by Dr. Yaxley and his colleagues. They basically did a randomized control study, a phase 3 trial, in which they divided 151 patients to retrobibic prostatectomy by open route and 157 by robotic route. So what were the results? At 24 months of follow-up, 91% participant in the robotic arm and 95% patients in the open arm were continent. That means no pad use. Sexual outcomes were also equal. There was no differences noted between the groups of physical, mental quality of life, bowel function, cancer-specific distress, physiological distress, urinary symptoms, or vitality. But in the conclusion, we advise caution in interpreting the oncological outcome of our study in the absence of standardization in the post-operative management between the 2 trial group and the use of additional cancer treatments. So the author here is trying to highlight a point which, when we read this article, that the surgeon who was tasked to perform the robotic surgery, a single surgeon experience, had experience of 200 robotic surgeries, whereas the surgeon who was doing tasked to perform the open group had experience of 1500 surgeries. So this point has been highlighted, that the experience of a surgeon, which is a key point highlighted in seeing the outcomes of any robotic surgery, was different there, and the data which was a little skewed. So we were looking for any other evidence which can come in favor of robotic surgery. So now came a meta-analysis, recent meta-analysis comparing all the modalities: retropubic, laparoscopic, and robotic. This was an analysis of data from inception 2000 to 2007, almost 2017, when this paper was published, about the outcomes of robotic, laparoscopic, and open prostatectomy. So these are the 4 curves. I will not give into the data much, but here you can see that the positive surgical margin and peri and post-operative complications in radical robotic prostatectomy are better than open and laparoscopic. The orange one is the robotic line, and the blue one is the open. The one key point I want to highlight here, if you can see this curve, post 2012, the down on the y-axis, you can see the years in which the surgeries were performed. After 2012, there has been a sharp increase in the complications and the positive surgical margins and the decrease in the continence after robotic surgery. And the credit of this goes to the US Preventive Task Force, which came out in 2012, and they said that actually they didn't find any benefit of PSA screening. And we are still not following this. Even 90 persons age 90 years are getting their PSA tested in our country, but they followed it there. And this led to surgeons getting more difficult prostates or surgery being done in patients who have progressed. A significant increase in the adverse pathology, Gleason score, and decrease in the nerve sparing, which I'll talk in further slides. So basically, the surgeons post 2012 in at least the West are doing prostate cancer, which are more advanced, and now even oligometastatic cases also. So when these outcomes were out, the effort was there from robotic community to how to improve their outcomes, how to improve the continence, how to improve the sexual outcomes. So for all of us, I think Dr. Lalit, Himanshu sir, everyone is aware, the continence and the potency depends on the network of nerves we have around the prostate, also known as the cavernous nerves, and the support of the bladder, the pelvic support of the bladder. So all these modifications which I have enlisted here were, the effort was to either preserve the nerves or in any way strengthen that component after the surgery. So we had the radius sparing radical prostatectomy, the nerve sparing technique, the hood technique, the wheel of Aphrodite, fancy name technique, preservation of urethral smooth muscles, suburethral plication, seminal vesicle sparing technique, and the single port technique. So all these modifications have happened in the last 20 years, and aim was to achieve better outcomes in respect to continence and potency. Apart from, I would say, radius sparing prostatectomy and nerve sparing, the rest have not shown promise. So I'll discuss the two in detail. So radius sparing prostatectomy is basically, as we know, radius, space of radius, everywhere with space of radius is basically the anterior vesicle, pre-vesical space. So we want to spare this space because it contains all the structures which are necessary to preserve the continence post-surgery. So they say we'll not go anteriorly, now we go posteriorly from the rectovesical pouch. And this is basically radius sparing prostatectomy. Described in 2010, preserving the endopelvic fascia, the arcus tendinous, puboprostatic ligament, the Santorini plexus, neurovascular bundle, could enable earlier continence compared to the traditional technique. That was the hypothesis. So we look at the meta-analysis. This was the master study. And radius sparing prostatectomy actually did better. 3 months post-surgery, the continence rates tend to be higher. Erectile function showed no significant difference. Positive surgical margins in localized T2 tumors were statistically significant. They had a higher positive surgical margins. So this was a catch here. And one more meta-analysis. This also shows that higher positive surgical margin rates, 15.2% compared to 24% in radius sparing. So the reason given for this is this radius sparing approach is basically an approach which is not the traditional one, in which not much surgeons have been trained. So going from an unknown route led to a greater learning curve, initial more positive surgical margins for the surgeon, and especially in the tumors which were locating in the anterior fibromuscular stoma. Now, which the studies are coming up, the surgeons who have experience of more than 200 cases of robotic, these surgical margins, positive surgical margins rates have come down. The next, second modification, which is worth mentioning, is the nerve sparing. I think this is more important than the radius technique because it has long-term effects on continence as well as impotence. For our non-surgical colleagues, this is the nerves I am talking about. In surgery, robotics, we call this a tram track appearance. This you can see like a railway track they're going. And this is a tram track appearance. This is Dr. Vipul Patel, one of the pioneer. I've taken him for one of the videos. And this is an anatomical description of the nerves. We have the prostate, we have the lateral pelvic fascia, and in between somewhere we have the nerves. So if we go inside that, it's called an intrafascial, interfascial, or extrafascial. The more closer we stay to the prostate, the more chances we'll save this nerve and better will be the outcomes. So that is the hypothesis. Preserve the entire neurovascular bundle from the apex and beyond. Retrograde nerve sparing means you spare the nerves first and then clip the arteries. Preserve the accessory neurovascular bundle. Try to preserve the accessory facial structure, the prostatic fascia, and the potency and continence rate have been seen to be better. So after all these modifications and everything, now in 2024, we are standing here and talking why robotics. So the literature has given almost the functional outcomes or trifecta as almost comparable. And why do we need robotics? robotic has lifestyle benefits to the patient elderly or the patients who had and surgery done earlier are now more frequently offered surgery because of the ease the robot effort offers less peri and post-op complication, the early discharge and early catheter removal. This all contributes to better patient care, early discharge from the hospital, and less cost on the our healthcare system. And this is what our next paper is about. Same day discharge in a surgery like robotic prostatectomy. The West now is offering same day discharge. They admit the patient 5 o'clock, 7 o'clock or the peri-op check is done, 8 o'clock the surgery starts, it will finish by 11:30, 12 o'clock. And 12 o'clock in the evening, we take our rounds and the patient goes home if he is living in the nearby community. So out of the 121 consecutive patients, 88 returned satisfactory questionnaire and 92% of responded stated that they prefer the recovery time at home rather than staying in the hospital. So this is what is possible by robotics. So this is the benefit it is offering. Role in 2024, since the era of the walls, the surgery role has changed drastically. In 80s to 2005, when the robot, the minimally invasive stuff came, many radical prostatectomy in retrospect were done in good candidates. These were the candidates with Gleason 3+3 or good surgical candidates. So we had a good outcomes reported initially. On the other hand, we have to note it was the same era in which a frozen section was done for lymph nodes. And if in a single lymph node is found on frozen section, the surgery was abandoned also. So it is not that the robotic initially grew up in easy surgery. There were scenarios in which advanced case was not done, and now it is being done. So the primary indication for radical prostatectomy is in nowadays is intermediate and high risk. Most of our patients who are DM-echo low risk are preferred going for active surveillance. PET scan is being used aggressively in management of prostate cancer, and we are getting more and more prostate cancer detected as systemic disease rather than the localized disease. Surgeons in 2024 are operating on men with even metastatic disease in whom these metastases would have been previously missed due to lack of imaging. So based on extrapolation of data from the Stampede trial, prostatectomy might be an appropriate first step in the multidisciplinary approach to prostate cancer in men with metastatic burden. And trials are going on, like radiation we giving to oligometastatic. Can we do surgery in these oligometastatic settings? Trials are on. So future, I see numerous new robotic systems are coming available. This will reduce the cost burden which the robotic system has to offer. We have our own Indian-made robots now available. They are being used. Reviews are good. Loss of intuitive monopoly and cost reduction is going on. Integration of AI to achieve better outcome. The 3D models, use of MPMRI to predict your nerves. Where are your nerves? Integration of robotic training in general surgery program. This has already started in West. And I think 15 years down the line, we will having general surgeons who will have the nuances. They will be knowing the nuances of the robotic systems. So in summary, role of robotic prostatic has evolved in the last 120 years. Initial high rates of morbidity has been replaced by a now safer surgery. Robotic is an effective way to deal with prostate cancer, even in low metastatic setting or salvage settings also. Safe provision of robotic prostatectomy has in fact led to dissemination of robotics in other fields of urology, and not even urology, gynecology and orthopedics and neurosurgery also. Although the surgeon experience, the volume of the center and modification in surgical techniques are associated with better outcome. I think the volume here, this word here comes Tata, because we have the volumes and we need to train people who are going to provide better outcome. Instead of a surgeon doing 5s, we can do 40 radical prostatectomy even in 6 months. So we have to concentrate on this. With respect to technical modification, I think as of now, we have reached our technical limits to provide the best outcomes. I think the future technology, AI will lead to the further increase in the pentafecta and trifecta. The robotic prostatectomy now is actually a part of multimodal management. And we might see like CA bladder, neoadjuvant coming first, and then the robotic prostatectomy come and sterilizing the pelvis. So once a surgery in low risk group, now it has become to a surgery with high risk group, occult metastatic and different metastatic disease also. That I'll end my slide. Thank you.
Dr. Shashank, very well covered. I want to like feedback. Now, role of AI is coming in a big way. whether it's in assessing the feedback of the surgeon, determining the outcome, prognostication, and also in the training. So I think within 2, 3, 4 years, this role of AI will come in a big way.
Yes, definitely.
So what is your take point on AI?
AI from I think it will help as a in our multimodal treatment also. But from talking from a surgeon point of view, I think it will help us better prognosticate our patient. That is the first before on taking a table with the 3D maps and the virtual models being coming up, we'll be able to better counsel the patients in terms of surgical outcomes on the console. I think it will help us better guide our dissection. That I think is the role of AI.
One more thing is single port. What is
Single port
critical process?
that I had
That-
covered. Yeah.
Right. So how will you decide about single port? You have to do single port or multi port.
I'll concentrate on what we have a scenario in our country. Instead of single port, I'll rather push for a more comprehensive robotic programs, and then maybe we can think about reducing the port size.
This study that you have mentioned that patients are getting discharged on day one. By the advancement of the single port,
Yeah,
this is
definitely.
the one big way.
Yeah,
because of the 4 port, there are 4 incisions. In
Yes.
single port, there is a single.
Single incision.
So that's why patients are getting discharged. On the day.
That
There
is
are
one
many
of
other things also.
Yes.
If we are performing extra peritoneal radical prostatectomy,
Mhm.
there is a limited space, then single incision port radical prostatectomy is a better way.
Mhm.
And when there is a history of like other surgery, inguinal surgery, there is a mess, there is other.
Then I think
peritoneal
transperitoneal is better.
surgery.
Transperitoneal better.
But if there is obviously we can go for the peritoneal approach. There is obviously abundant space, then transperitoneal is better. And lymph node dissection is also better in
Better.
transperitoneal.
One thing I would like to add, this early discharge. It is not only the single port. When I was looking for some time with Dr. Manan, he's doing this. He is one of the pioneers for this daycare robotic radical prostatectomy. So what he mentioned that admit the patient early in the morning at 5, go for the surgery in 8 and finish it within 1.5 to 2 hours and discharge the patient in the evening. So we have come from an era where where radical prostatectomy patient we used to admit it for 5, 7 days. Foley is kept down for 3 weeks or 4 weeks. Nowadays, Foley is removed within 5 days. So one thing is that robotics has definitely improved the vision, the clarity, the 10 times to 40 times magnification into the pelvis and surgical field. But we need to learn as a surgeon that I can quote a famous saying from Dr. Popada, Dr. Mahendra Pal is there. Here. So he used to start in slides when he talked about robotic surgery. So कहते हैं कि fool with a tool is always a fool. So the basic thing हमें यहाँ पे समझने की जरूरत है कि it is not the machine only. It is basically the surgeon. So why we still keep remembering Dr. Walsh? Because Dr. Walsh ने अपनी surgical skills and the anatomy is very important for the surgeons. So the whole scenario changed for radical prostatectomy when Dr. Walsh I can say discovered the neurovascular bundle and the anatomy. So that is the main crux. So preserving neurovascular bundle, preserving the support system in the anterior space, regium space, preserving the bladder neck. Nowadays, which you left mentioning that there is a lateral approach to radical prostatectomy. So that is the absolute preservation of the bladder neck where the urethra is preserved. So length of the urethra from the bladder side as well as from the membranous side is very important. So again, the skilled surgeon is the most important part, and the machine comes as a second. Thank you, sir.